acute post-operative infection is still a delimited situation, but delayed spine surgical post-operative infections are even a bigger challenge. Particularly when a patient has very subtle symptoms, wound has healed completely, and there are no systemic signs. So mind you, this is the classical triad that the wound has healed, symptoms are only subtle, and there are no laboratory or clinical findings to suggest that this is a case of infection. Like in this particular case scenario where a 53-year-old female who's obese, diabetic, underwent a TLIF, had some post-operative wound which was washed, wound got completely healed, patient has no systemic features, but there is a sudden resurgence of back pain at 13 weeks post-op, and the pain is only increasing with time. There is no leg pain, there is no fever and no systemic complaints. Now in this scenario, where the primary wound has healed, it is only back pain post-operatively at 13 weeks post-op, you can easily shove it off saying, "Arey, post-op back pain to hota rehta hai," and you can just send the patient away, like it happened to this patient. That post-operative back pain is so common and it might be just a spectrum of increased back pain. And this is the commonest thing that happens, which we often lead to making of a bigger and a larger amount quantum of infection in the spine there. The biggest problem, like someone asked here, how do we confirm that this is infection and nothing else? Is laboratory diagnosis going to help us? Is MRI with the suspicion of post-operative edema, scarring and artifacts there going to help us in diagnosing infection? And if at all we suspect it as infection, should we not start him on empirical antibiotics? Because there is nothing inside there to take a culture at least in the early 12, 13, 14 weeks time. And if it is infection, will only debridement work, or this implant which is lying there needs to come out? And such similar dilemmas are extremely common and have to be paid meticulous attention when it comes to delayed surgical infections. Now, I must tell you that delayed post-operative surgical site infection is not something that is uncommon. Unfortunately, despite having so many dilemmas, our understanding, definitions about delayed surgical site infections are very, very minuscule. And all our understanding is currently being driven by the arthroplasty group, which has clear-cut definition of what a periprosthetic infection is, what is early infection, what is delayed infection, the duration is described, the diagnostic modalities are described, the antibiotic regime is described. Whereas delayed surgical site infection in spine, neither is there a clear-cut definition nor a duration, and there are no directives about how to manage these implants in there. Now, one thing is extremely clear, that the only way to diagnose these delayed surgical site infection is do not let go away post-operative back pain or resurgence of any symptom in the post-operative regime. For example, a patient comes to you with 3 हफ्ते सब ठीक था and 6 हफ्ते के बाद वापस back pain आ गया है, so please don't just let that patient go away. It can just be a sign of infection. Mind you, 10% of your patients are infected if they have a new onset of back pain, leg pain, or a sudden onset of symptom which cannot be explained otherwise. And simple back pain also can be a only sign and symptom of post-operative delayed infection lurking out there, and it needs a very, very high index of suspicion. Now, the dilemmas about delayed surgical site infection don't just go there by how will they present, because they can present only with subtle back pain there. The dilemmas are, how do we prevent these delayed surgical site infections, how do we diagnose them, and how do we manage them, and closure, antibiotic prophylaxis or antibiotic therapeutic treatment in such patients again remains there, no guidelines in there. We all know how to prevent delayed surgical site infections. Prevention is the best strategy, and the only answer to this is know the risk factors well. Now, understanding about these risk factors pre-operatively is very important, not only to suspect them in post-operative era, that any patient who had pre-operatively these factors has a high chance of developing delayed infection when he comes to you post-operatively, but also to keep your patient on the same page by counseling and keeping a special mention about these things, at least in your consent form, that you have a high index of suspicion, you have a high chance of infection coming up in post-operative phase. Particularly, we must also emphasize that now these risk factors are not restricted to medical comorbidities. It is all about lifestyle. Age being an independent factor to delayed surgical site infections, obesity, lifestyle issues. In fact, proteinuria in urine, which I routinely do as a check in pre-operative phase, is also a marker that if this patient had proteinuria pre-operatively, a new back pain happening after 6 weeks, 8 weeks can be a potential infection lurking in there. arthroplasty group has also mentioned very clearly that in these patients who have high risk factors, a tailor-make prophylaxis is very, very important. That you have to do a MRSA guidance or a nasal swab check at least 3 weeks pre-operatively to determine what kind of antibiotic is suitable for these high-risk group patients and what kind of antibiotic should be given for what duration of time. Intraoperatively, we have been using all kind of ultra clean sepsis in almost all theaters, but something that comes very handy and particularly useful in these high risk group patients is a wash with betadine lasting there for 20 minutes and a vancomycin powder, even in patients who do not have established infection, as a measure to prevent infection, is something that comes very handy in spine patients with high risk factors. Now, a patient coming to you with post-operative back pain at the end of 4 weeks or 6 weeks or say 13 weeks post-operatively, does this mean that every patient with post-operative back pain has infection lurking out there? The answer to this is yes, unless proven otherwise. Because MRIs, ESR, CRPs, they do not really help in there. And the only thing that helps to catch them early is clinical diagnosis. So every symptom which is new in onset is disturbing patient's lifestyle and was not there earlier, a new resurgence of symptoms in a delayed 6 to 12 weeks time is something that can be actually considered as infection lying in there. Now, we also must understand that one-time raise of ESR or CRP has no value, and the moment these patients come to your clinic with any new symptom, you must not only do a ESR, CRP, serum procalcitonin as a baseline, but also do repeat sequential ones at every 3-day interval to see if there is an increasing trend, which is a sure shot pathognomonic sign of infection lurking in there. MRIs are useful only after 3 months, because till 3 months post-operative artifacts, edema, scarring will prevent the clinical diagnosis or radiological diagnosis of infection there. However, findings like end plate erosions, fluid pockets in psoas muscle area or bone marrow generalized edema is something that can be considered as a finding that infection is the cause of these symptoms there. Yes, PET-CT scan comes very handy, but again, it only becomes pathognomonic only after 3 months, because till 3 months post-operative normal changes can also mimic like an infective sign in there. And so, the only way to clear-cut diagnose them is not only increasing trend of lab markers, but the clinical suspicion that this can be an infection in there. Now, once you have diagnosed that this is infection in there, you have got a high index suspicion, you know that this symptom is explained by infection there, lab markers are showing increasing trend, then the answer to how do we manage them is just be as aggressive as you can. Because this infection, the later you deal with, empirical antibiotics have absolutely no role to play in them, and you have to be extremely aggressive and radical in debriding them. And the principles of radical debridement are very clear. We all know that if you suspect infection in a musculoskeletal system, you have to remove all infected material, all necrotic tissue, particularly from the intertransverse gutter areas, all slough, all sequestrum has to come out. Even if it means creating a bigger defect, but all necrotic muscle tissue has to come out, even if you end up creating a bigger defect which may require either a secondary closure or a VAC closure or a plastic surgeon coming in at a later date. But please do not leave this any kind of slough material in there, because that can be a potential growth of bacteria in there. Now, if it means reconstructing it, you have to go and reconstruct it. Particularly in patients when it is only post-operative discitis with no implant in there, just debride the disc space, go and reconstruct it using bone graft and stabilization implants there. Don't shy away from putting an implant even in infected spine. It really works well. Some case examples there. Now, the biggest dilemma that as an orthopedic and spine surgeon comes into our mind is what to do with the implant. If I have done a T-lift and I have diagnosed it to be a infected spine at 12 weeks or 16 weeks post-operatively, should I remove it at the risk of leaving behind mechanical instability, particularly in patients with trauma or scoliosis, which will not only result into instability but also risk the loss of correction, further proposing neurological insult to the patient? Or should I retain it at the risk of curtailing the infection in there and requirement of multiple debridements? There is a clear-cut guideline that implant must be removed in these conditions if you have diagnosed it to be a very delayed, like an infection diagnosed after 12 weeks, implant has to come out, because these infections are caused by low virulence microorganisms which are known to not only be immune to the body's immune system, but also are multi-resistant to bacteria, to the antibiotics, and they will not get cleared unless until you remove those implants there. And these low virulence bacteria are known to create polysaccharide biofilm even on titanium implants. So that implant has to come up if the infection is diagnosed 12 weeks or post after that. Any presence of systemic sign like fever is a sign of sepsis, implant has to come out. Secondary reconstruction can still be done, but that implant has to come out from there. Any loose implant halo around the screws has to come out. Stainless steel implants cannot be kept in there. And if the primary debridement has not helped and patient still has lurking infection, the implant has to come out from there. Implants can only be retained if you have got an early diagnosis, less than 12 weeks, preferably less than 6 weeks. You can do a washed, thorough debridement and keep the implant there and watch them thoroughly. Now, retention principle means you have to take a peri-implant culture from there, and if bacteria is found, go do a second visit and follow them up and remove the implant later there. The midway regime, now there is recommendation that implant exchange should be done. Whenever you have removed the implant there and you have a risk of neurological insult due to mechanical instability left behind, you should remove and exchange the implant. And the principle to these are that remove the whole of implant, create the screw tracks, debride them, put in antibiotic there, do betadine wash, and do a reconstruction either one level above, below, reconstructing it not only in the posterior but also in the anterior area. And wound closure will depend upon how much defect has been created. Don't shy away from putting in a vac there, which can be closed secondarily if the infection was really virulent there. Antibiotic regime, never empirical. You have to take cultures, and preferably sonification of the implant that you have left in out there should be done to find out. And minimum 12 weeks of antibiotic, out of which 2 weeks should be injectable, is what is recommended. So to summarize, clinical acumen and high index of suspicion is extremely important, and subtle signs and symptoms post-operatively done coming up to you at even 6 weeks post-operatively should be considered as an infection unless proven otherwise. Modern investigations can help you to diagnose infection very well, because the routine laboratory investigations and MRIs may get hidden by the post-operative artifacts and scarring left out there. Implant retention is often difficult in delayed surgical site infection and should be removed, and midway exchange is the answer to the instability that we create after implant removal.